I like this sweater.
Good afternoon. Good afternoon to everybody in this room and to people in the Blue Cross Blue Shield Auditorium. I'm Barbara Reimer. I'm Dean of the UNC Gillings School of Global Public Health, and I am so glad to see you here today. I want to thank you all for being here for the first in the school's new Dean's Inclusive Excellence Lecture Series. I'm so excited about how much energy there is in this room, in the hallway, downstairs. And I can't imagine a better first speaker than UCLA Fielding School of Public Health professor, Chandra L. And I can't wait to hear what she has to say. We are so proud that she is a Gillings alumna. And in a couple minutes, Ribisl, who is Chair of Health Behavior, and the Joanne Earp Distinguished Professor in Health Behavior, will tell you a little bit more about the speaker. Kurt is a leader committed to inclusive excellence, and I am so proud of him. I wanted to just take a minute to put the lecture series in context. It is really important for this school. We are working persistently and in a committed way to be a school that embodies inclusive excellence. This series is a central element of our school's Inclusive Excellence Action Plan, which is led by Kauline, who is Assistant Dean for Inclusive Excellence and Associate Professor, with many strong and committed participants from around the school. The lecture series is also a tangible expression of our school's leadership commitment to inclusive excellence and to learning together how to combat racism. Our chairs are so committed that they agreed that each of them would host a lecture, starting with Kurt Ribisl, in collaboration with Dr. Cipriani. Many people across the school have worked on this event. No matter who we are, we have much to learn about how to dismantle racism and create more equitable and just societies in this country and around the world. I believe that we need to come at this with the humility to recognize that we all must learn and act together, whether we have the lived experience of racism or the benefits of white privilege. None of us have all the answers. I don't have all the answers. This lecture series is one part of our commitment to inclusive excellence. And I'd like to call on Kauline Cipriani, our Assistant Dean, to make brief comments, and she'll be followed by Kurt Ribisl. Thank you.
Thank you, Dean Reimer. Good evening, everyone, and thank you all for being here. November is American Indian Heritage Month, so I want to begin by acknowledging the history of the land upon which this university is built. The indigenous people of this area are the Occaneechi Band of the Saponi Nation. North Carolina is home to 8 indigenous nations and has the largest indigenous population east of the Mississippi River. We acknowledge and give thanks to the first peoples of this land and their descendants. We look forward to building upon the honored memories and goodwill of all who walked and labored here before us. The Dean's Inclusive Excellence Lecture Series is just one of the many elements of our school's new Inclusive Excellence Action Plan, as Barbara alluded to earlier. This plan was developed by all of us, the faculty, staff, and students at the Gillings School, in response to the question of how best might we operationalize and expand inclusive excellence within our school. The Inclusive Excellence Council, which consists of faculty, staff, and students from across Gillings, is tasked with the oversight and monitoring of our strategic plan. The Inclusive Excellence Lecture Series aims to heighten the visibility of and our engagement with major efforts to understand and dismantle racism and other forms of oppression, and to highlight initiatives to create a healthier, more equitable, and just society both locally and globally. Undoubtedly, the Gillings School has a long-standing commitment to social justice and inclusion. Our historical and current commitment to equity, access, and inclusivity was recently nationally recognized with the 2019 Health Professions Higher Education Excellence in Diversity, or HEDA Award, from the Insight into Diversity magazine. We were one of only 2 schools of public health to receive this award, and we were both the only schools of public health to have received this award since its creation. So this calls for a celebration. So the party will be this Thursday, November 21st at 1 p.m. in the Armfield Atrium. You are all invited, and there will be cake. Now that that's over with, to the real reason we are all here this evening. In the introduction to her newly released publication, Racism, Science and Tools for the Public Health Professional, Dr. Chandra Ford and her co-editors recount the process that led to the book's final title. I would like to publicly thank you, Dr. Ford, and your co-editors for courageously and explicitly using the word racism in the title. We cannot begin to address that which we will not name. That's right. At this point, Dr. Ribisl will come up and introduce Dr. Chandra Ford, after which Dr. Yesenia Marino, our Director of Inclusive Excellence Education and Training here at Gillings, and another HB alumna, will facilitate the Q&A session.
I'm just thrilled to introduce our speaker. This is just a fantastic opportunity to have the Dean's Inclusive Excellence Series. And when we were at the Department of Health and Behavior was allowed to have the inaugural speaker, the immediate and natural choice was going to be Dr. Chandra Ford. So we are so excited. As we heard, she's the founding director of the UCLA Center for the Study of Racism, Social Justice, and Health. She's also an associate professor in their Department of Community Health at Fielding. And you know, this summer I was at UCLA and I had some extra time. I was able to visit with Chandra and just hear more about her work, some of the behind the scenes on her book. And it's just, I mean, she's been working, she and the other team of editors have been doing just a phenomenal job on this work. This is really, really going to be an important book. I'm convinced this is a sort of a landmark event. APHA was wise. They talked in the book about that they commissioned this book and approached the editors, so they were super smart in the timing of this and the focus on racism and not just race. And there's a whole section in the book you can read about that. They weren't as smart when they picked how many books to order. So APHA, I think they've sold out in the first day or a matter within hours. And so the whole conference, every other book was like stacked up, and you couldn't get this one. And then I had to order from like 3 different sources to make sure at least one of the sources would come through. So, and I had Dr. Ford autographed mine today, so I'm going to be handing on to this one. And it's really important that we have this dialogue and at this time. And I think one of the best things about this book, there are so many books and papers that talk about health inequities and disparities, but this one talks a lot about solutions, what we need to do, and it's really comprehensive. There's a whole section on what academia needs to do. And I think we're going to be taking an analysis over the coming months and years and seeing how we can do a better job, because I think there's a lot of lessons that we have here. So I'm so proud to introduce Dr. Chandra Ford. Thank you.
Thank you for that generous and very warm introduction. My visit here to UNC has just been someone calling. Just been delightful. So I feel deeply humbled, Dean Reimer, to be invited to deliver remarks at the inaugural lecture of the Dean's Inclusive Excellence Lecture, this new series. So thank you. I also want to thank Dr. Kurt Ribisl, Associate Dean Cipriani, and Dean Reimer. I want to let you know that I was deeply moved by your remarks at the UNC reception at APHA this year. Clearly, UNC is choosing to try to address the many challenges that we are facing across the country. And while no one can claim to have the solution to these challenges, if any school of public health is equipped to handle racism, UNC is certainly well positioned to take the lead to do so. Allow me to acknowledge that I conduct my work in Southern California on lands originally inhabited by and cared for by the Gabrielino Tongva peoples. And no doubt the displacement of these peoples, who are still around today, has enabled my land-grant institution, UCLA, to thrive and to now emerge as one of the top public state schools. And this acknowledgement, coming from someone working on a book about racism, is a humbling reminder that even those of us who have legitimate claims about U.S. racism are nevertheless complicit with and benefit from historic and ongoing injustices visited upon the indigenous peoples of the Americas. I also acknowledge that the knowledge of 1619 informs much of my thinking today and more broadly about my work this year. So that may, you might see that in my remarks. So my overarching aim today is to explore ways in which theory, and by theory I mean either academic sources of theory or theory derived organically through the lived experiences of community members, theory and research methods can serve as useful weapons in this war for health equity we now find ourselves confronting. I'll start by briefly contextualizing the problem, propose that research can be a powerful weapon for advancing the cause of equity, and illustrate why, for such research to be meaningful, we have to be more thoughtful about how we use racialized theory and methods. And I'll conclude by offering just some brief excerpts from our recently published book. So it's easy to see today that a war against racial and ethnic health equity and justice, and also more broadly other social categories, is ongoing in our country and around the world. And many commonly, but erroneously, describe it as the reemergence of racism. Now, I'm picking on my own city, Los Angeles here. Looking at hate crimes data, it's easy to understand why people might see it this way. But these data for LA are similar to what we see for national patterns, and that is that racism has been with us in the forms of the most egregious kinds of racism, hate crimes, for at least the last decade. And the number of hate crimes and overt expressions of racial antipathy, for example, what we might see in the media, that are directed against racial and ethnic minorities as well as religious minorities, have actually been increasing since approximately 2014. And the explicit violence and the boldness with which it is carried out makes us all take notice. But the patterns we observe today are not entirely new. For instance, though not shown here, the hate crimes data from the last decade reveal that the racialized groups that experience the highest rates of hate crimes, in particular blacks and Jews, have historically been subject to U.S. hate crimes based on the racialization of people based on race and religion, respectively, though obviously rates of Islamophobia-based crime and anti-Muslim racism are also increasing. But hate crimes represent only the most extreme forms of racism, and in my own work I'm increasingly interested in thinking about the ways in which liberal forms of racism operate. And what concerns me here is how they operate in liberal contexts, including professional contexts, such as the helping fields, like public health. Now, racism has been defined in a number of ways. A number of us in the room have actually published different definitions of racism. I'll offer two definitions here that I think are particularly useful today. Kamara Jones, former APHA president, has defined it as a system of structuring opportunity and assigning value based on the social interpretation of how one looks. So what we tend to call race. And that structuring unfairly disadvantages some individuals and communities. It unfairly advantages other individuals and communities, and it saps the strength of the whole society through the waste of human resources. I also appreciate the definition offered by the social geographer Ruth Gilmore, who defines racism as, quote, the state-sanctioned and or extra-legal production and exploitation of group-differentiated vulnerability to premature death. And what I like about this definition is that it is helpful for studying health inequities because it draws attention to the structural nature of racism, rather than allowing us to focus primarily on proximal interpersonal determinants. And it emphasizes that we cannot think about racism without thinking about the implications for the body and for populations. So this is a fascinating time to be studying racism. In the early 21st century, racism operates in both seen and unseen ways. Those that tend to concern us most are the seen ways, so these are the hate crimes, the very overt and egregious forms of violent crimes. But the unseen ways may actually be even more important because they continue to constitute what critical race theorists say are the major ways that racism operates in the early 21st century, though one must be able to perceive them in order to combat them. And here, critical race theory, I think, can be seen, if we're sticking with the battle metaphor, as night vision goggles, helping to illuminate the ways in which things are going on, but we are unable to perceive them. So that's in society more broadly. The picture within our field is mixed. On the one hand, the number of studies that treat racism as a social exposure and attempt to estimate the implications for population health has grown exponentially over the last 2 decades. There's also a burgeoning literature on critical race theory that has emerged, and there are a number of dynamics with that. There are critical race theorists from fields such as law who are publishing in the public health literature. There are health equity researchers who are using critical race theory to conceptualize their work or to discuss their findings, framing them in a more critical framework. And there are a small but growing number of health equity researchers who are trying to find ways to apply critical race theory empirically. All of that is good, but the NIH has not yet, from my vantage point, established a clear priority for addressing racism, consistently and systematically prioritizing it. Outside of the work of, for instance, the National Institutes of Minority Health and Health Disparities, and perhaps the National Cancer Institute. Public health is both an applied field and an academic one. And several chapters in a new book highlight the anti-racism work of public health. For instance, Chapter 2, and those are the images on the right, which was co-authored by the late Bill Jenkins, Victor Schoenbach, who is in the room, Diane Rowley, and to a tiny bit myself. This chapter places contemporary work on racism in its proper historical context. It describes many individuals and organizations, as well as the formal and informal actions taken over the years to move the field toward committing to the achievement of health equity. Included among the many archival items in the chapter's appendix are a picture of the Black female epidemiologist at CDC, whom Dr. Jenkins referred to as the Magnificent Seven, as well as the landmark 1985 publication the Heckler's report of the Secretary Heckler's Task Force on Black and Minority Health, which provided the nation's first systematic documentation of racial disparities across health outcomes. A more recent example of fighting for health equity within the context of public health practice that names racism explicitly is the Accountability for Cancer Care Through Undoing Racism and Equity, or ACCURE study. The authors of this project were involved with the Greensboro Health Disparities Collaborative, which I had an opportunity to meet with yesterday. Thank you. And they describe this endeavor as, quote, a systems change study created by a community academic medical partnership that draws on anti-racism principles to disrupt the pathways by which structural racism impacts cancer care for stage 1 or 2 breast and lung cancer patients. So work has been happening in the area of public health practice, but what I want to focus on today is actually the implications for research. With respect to research, public health has sometimes been seen actually as part of the problem. Much of the foundations of biomedical research are rooted in racist efforts to document inherent biological differences between the races. And I would say that we now look back and refer to them as racist endeavors. However, at the time, the people conducting that work did not necessarily see themselves as involved in or committed to racist endeavors. And that's a challenge we too must think about. How might the work we are doing today reinforce or contribute to the reification of racial differences in ways that we would regret years from now? Historically, public health has served as a voice of authority, legitimating racist thinking on behalf of the society. And here I would point at the example of immigration policies, which have historically been racialized. Even before we had the population demographics that we now have, where we do tend to count people in terms of people of color or not. Even in the early 20th century, that racialization contributed to the banning of people who were from nations outside of Central and Northern Europe on the grounds that they would bring physical or social disease to the nation. And the field has had an exploitative relationship to many communities. And one example my doctoral student Natalie Bradford recently presented at APHA is on the treatment of Chicago communities as, quote, a social science lab, unquote, by researchers at the University of Chicago and elsewhere. So despite the impetus that we might feel to sort of jump in and suddenly address the forms of racism that we see in our society and perhaps even in our field, I think it's important to take a step back and think about the role that theory might play in informing the actions that we take. My work is based on critical race theory, as many of you know, and through it I strive to advance the cause of equity by challenging racist research directly, by raising overlooked questions and studying problems of import to marginalized communities, and by developing new approaches and tools. And this is particularly important because, as Audre Lorde has said, the tools that we use determine the nature of the work, and the nature of the work determines the findings we will generate. So to study distal determinants, really any distal determinant, but including racism, requires an articulation of the theory guiding the work. And I use the term theory here to refer to a heuristic used to explain abstract, interrelated concepts systematically, or to predict events or situations systematically. Now, with respect to critical race theory, Although the term theory is in its name, it is not merely a theory in the same way that we might think of, for instance, a behavior change theory. Rather, it is a movement. In fact, it is an anti-racist intellectual movement that originated in law schools among scholars of color. And that movement originated in the late 1980s as a way to try to explain the ways that racism operates in subtle, often imperceptible ways in the current post-civil rights era. Public health critical race praxis is just one of a number of health equity-based offshoots from critical race theory. And my colleague and collaborator, Collins, Ariambua, and I developed it in order to try to provide a lexicon for talking about these ideas in more complex ways and carrying out empirical research that marries the rigor of critical race theory with respect to racial phenomena and the rigor of science and health equity methods with respect to research and with respect to empirical research. Now, the names of these approaches, critical race theory, public health critical race praxis, are quite academic. But typically, the academic names are used only to communicate within academic contexts. Our main priority in terms of working within community is to center the margins and to proceed doing this work. And we generally do not even use the names when we're doing that. Critical race theory has many constructs. I want to highlight just 3 today that are relevant to understanding the health implications of racism, or what I would say is to helping us think about how we might use them in research on the health implications of racism. The concept of intersectionality is one that people increasingly use to refer to multiple co-occurring social identities. That orientation is actually somewhat backwards. It suggests that having an identity drives the creation of oppressive systems of oppression. In fact, the systems of oppression construct differences across people, essentially constructing populations. And then it affects people according to the constructions that it created. So a deeper understanding of intersectionality would really emphasize the ways in which these systems of social oppression interlock and thus create compounded, synergistic effects for those persons who occupy multiple minority social identity categories. There are a number of research questions that critical race theorists and public health are trying to answer with respect to intersectionality. They include, do some identities or systems matter more than others? How should interventions approach which identities or systems of oppression should be targeted? Is it possible to capture intersectional effects statistically? Critical race theory's whiteness as property concept clarifies what whiteness is and explains how the U.S. legal system has worked consistently to protect it. Property issues have been intertwined with race since the nation's inception because to achieve its wealth, the law would first have to reconcile at least 2 apparent contradictions. On the one hand, it had to somehow provide a rationale that would allow white settlers to take Native Americans' property, their land, lawfully. At the same time, it had to wrestle with whether slaves, whether Africans, were people, property, or both. Fundamentally, whiteness is not simply an indicator of phenotypic characteristics, such as skin shade, but it is an indicator of one's social status relative to citizenship. So whiteness is the highest social status relative to full citizenship. That is, to be white is to have access to the fullest of rights and privileges of being a citizen. Thus, whiteness can be thought of as the gap that exists between people defined as whites and all others. That's a privilege gap, that's a power gap. According to the brilliant